Welcome to the Next Human. My name's Arav, and today I'm joined by Dr. Freddy Nguyen, a research fellow at MIT who's working to advance functional precision medicine through photonics and nanotechnologies. His career encompasses breakthroughs in cancer diagnostics and the development of nanoscale sensors, placing him at the forefront of personalized healthcare innovation. Thank you so much for joining me today, Doctor.
Oh, it's my pleasure. And please call me Freddy.
Maybe once I get my own PhD and MD. But the first thing I want to ask is just kind of, can you walk me through your life, I guess, like where did you grow up, where did you study, and where have you worked?
Yeah, well, it's certainly been a very circuitous but fun journey along the way. Actually, I was born and grew up in Paris, France, and then moved to Houston, Texas,
Mhm.
and then did most of my middle school, high school in Little Arkansas. Um, but I did my undergraduate at Rice University in Houston, and really I went to college, certainly had the mindset of going to medical school after that, but really didn't know a whole lot about research at the time, but ended up starting to explore that when I was an undergraduate. I just absolutely fell in love with science and engineering. Um, I had the opportunity to work with Bob Curl, who was a professor in the chemistry department there, also one of the Nobel laureates for chemistry in '96 for the Buckminster fullerene, and really helping create, be part of the team um, that started the nanotechnology field, especially based on carbon nanotubes
Mhm.
in that chemistry. Um, but what was most amazing to me about that experience was the fact that even though I was, I think, a sophomore, junior at the time, um, Ian, and despite his accomplishments, he was very much a down-to-earth individual who really cared and valued about not only teaching but mentoring the future generation of scientists and engineers as part of what he was doing, which really left a lasting impact on me even to this day, and why I still dedicate quite a portion of my time working with undergraduate students, mentoring them, advising them, whether that's on the research side or in teaching capacities or in other roles as well. After my undergrad, I took a year off to go work in a lab in the MIT spectroscopy laboratory and further explored my interest in biophotonics. When I was at Rice, I worked on a collaboration between Rice and Baylor College of Medicine, trying to develop a new way to do DNA sequencing that was going to be much more sensitive and specific without needing the use of PCR at the time. At MIT, I worked on a project focused around now combining a lot of different optical techniques. So, looking at light scattering techniques, looking at Raman spectroscopy, as well as fluorescence techniques to all targeted at cancer diagnostics. So, really, can we combine all these photonics methodologies to try and see can we do better at detection of cancer and diagnosis of cancer?
Mhm.
Um, and then that really solidified for me that research and science was something that I really wanted to do, and more so in the photonics space. So then decided to pursue my MD PhD at the University of Illinois in Urbana-Champaign, where my PhD was focused on technology called optical coherent tomography, which is pretty much ultrasound is the interference of sound waves to create images. Optical coherent tomography, or OCT, is the interference of light waves to create those images. And so what we really end up getting is, the equivalence of a histology site. So basically getting down to cellular level, micron scale, sometimes even sub-micron scale resolution type of imaging, without ever having to physically cut the tissue, section the tissue, or stain the tissue to be able to visualize the cells. And similarly, been using that for development to give as a tool for surgeons in the operating room to guide the surgical resection of primary tumors to make sure there's not any cancer cells left behind,
Mhm.
as well as for the assessment of lymph, which are usually what drains from the primary tumor sites as well, to kind of determine whether has the cancer started to metastasize to other places or not.
Mhm.
Um, And from there, I came back to MIT and started to dive deeper in the nanotechnology space. So worked on the development of single carbon nanotubes as optical nanosensors, largely for a few different applications within the cancer space. What we were really trying to develop sensors for was how can we probe um, the effectiveness of cancer treatments. And it's the fact that even though there's been a lot of advances in new therapeutics, more targeted therapeutics for cancer patients, even with the targeted therapies, the success rate is still somewhere in the 40 to 70% in terms of a patient's response to therapy. And at this point, the way we determine whether therapy is working or not is largely based on imaging modalities to see, is there physical shrinkage of the tumor? Is there less activity coming from different tumor sites? And then, ultimately is doing biopsies at the site to determine if there's been any changes on a molecular level, during and post-treatment. But as you can imagine, those processes take a long time. Usually it takes a matter of weeks to months to determine the effectiveness of therapy. And so really our goal was, can we develop a system where we can get to that answer in a matter of days or at most a few weeks. That way we can, determine is treatment effective or is it just working okay, but it's subtherapeutic. So can we use this information to guide the frequency and dosing of various therapies, or do we need to switch them out to a whole different modality altogether? Of course, with all the goal of getting patients to the most effective treatment as soon as possible. So with that, we were developing sensors for chemotherapeutic drugs themselves to determine drug delivery and the pharmacodynamics and kinetics of that, as well as cell death markers to determine, how was the cancer cell responding to the treatment. After my postdoc at MIT, I then went back to my clinical training. So did my residency in clinical pathology and laboratory medicine at Mount Sinai Hospital in New York. And the reason for that was really to further hone in on not just knowledge of medicine from, what is the disease, what is the biology, but a better understanding of, what is the clinical workflows, how are the patients being treated, what is the interaction between different disciplines within medicine. And essentially, it's much more about sort of the practice of medicine, the business of medicine, because it's hugely important for having a good understanding of that, and especially in technology development, where you're hoping that there'll be uptake in the medical field. And so having an understanding of those aspects are super important to make sure that the solution you're developing will actually get adopted, right? And then lastly, did my clinical fellowship in transfusion medicine up at Dartmouth last year, and now I'm back in MIT again.
Awesome. Yeah, I mean, sounds like you had pretty long and fascinating journey, I guess, through I guess your early days at Rice and then to now back at MIT. I guess like what would you say that kind of initially drew you to sort of like the intersection of medicine and technology? And like how has it, I guess, like changed throughout the years?
Yeah, so I think in high school I was always interested in chemistry and math, and that's pretty much what I went into Rice thinking about in terms of what my majors were going to be, and actually kind of stuck through that through all of my undergraduate career. Um, but I will say I did quite a number of different research projects. I only highlighted, the main one that I worked on as an undergrad. But what really grabbed my attention was, on the engineering side, especially on the physical chemistry side, was that, there's just something satisfying about building things physical. And that was everything from sort of like the hardware component of it and the optics component of it, to even on the software development side and the instrumentation and coordination of that, the data analysis and so on. To me, was all very fascinating to really work at a place where you could bring in multiple fields together to address a particular problem that we were working on. Um, and I would say over the years that has continued to be true. I would say the thing that probably has hone me down even more is really being motivated by where the problem spaces are. And I think that's really been around, make sure that what I work on is very much, a clinical unmet need. It's very much problem centric, human centric in terms of how we develop these solutions. Because what I often say is that, there's plenty of great technologies out there, but finding that right fit between technology and the unmet needs in the clinic is super important. One example that I always give is, optical coherence tomography, OCT, has been around since the mid 90s, early 90s now, first developed by MIT. And it's gained the greatest traction in the field of ophthalmology. Nowadays, it's pretty much standard of care for to be in the ophthalmologist's office is to have an OCT instrument. And since then, as a field, we've certainly tried to look at other applications of OCT, whether it's been for cancers or cardiovascular diseases, looked at a cross section of different organ systems from their surgical suite to GI to and other spaces. But nothing's gained as quick or as great traction as it had been in ophthalmology. It's not to say that it doesn't have any utility in other fields, is that it's just to kind of demonstrate once you have a really, really good, essentially what some people might refer to product market fit, the adoption can accelerate very, very quickly with the technology like that. So, and to me, so that today, whatever I work on, it really stays grounded and making sure that it's the patients at the end that are driving what we work on and the research that we do and the technologies that we develop.
Awesome. And you talked a little bit about earlier about the work you've done in spectroscopy and the techniques for like cancer diagnostics. Could you just touch a little bit on that work and just kind of like how that work is, improving accuracy and speed of cancer detection, and how it like impacts patient care?
Yeah, so I think the different technologies I've worked at have been at different stages of the patient journey, right? Or their experience with cancer, whether that's been early on in the more screening and diagnostic stage, which is some of the work that we were doing, in that first time that I was at MIT in the spectroscopy lab, looking at diffuse reflectance, light scattering, intrinsic fluorescence methodologies that was used to in the context of cervical cancer screening and trying to identify whether we could identify lesions earlier in that way. When I did my PhD with optical coherence tomography, which is another light scattering type of technology, there it was much more. Now you were shifting more on the treatment side because essentially you were in the operating room helping surgeons, making sure that not only could we identify whether there were still remaining cancer cells left in the once the primary tumor was removed from the site, but it was really to make sure that not only, and if there was, the surgeon could then go in and take additional tissue out right there and then, as opposed to the current process at the time was the fact that they would do the primary version of the tumor, they would send the specimen to pathology, they might do a frozen section, or they might take it back to the lab to do more permanent fixation and do the analysis that way. But usually by that time, then the surgeon would more or less, finish the surgery and the patient would be discharged. And so depending on what the pathology results were, which could take, maybe a day, a few days to get back, they may not get an answer on whether the margins of the specimen they took out were completely clean. And when I say clean, meaning that there's no cancer cells found on the surface. If there were cancer cells found on that surface, that problem is there were still cancer cells left behind in the cavity where the tissue was removed. So now we would reduce essentially, the need for a patient to come back for a second surgery to remove more of the cancer. We would reduce, potentially the recurrence rate, because if we happen to leave, obviously, cancer cells behind, the recurrences would go up. And then in the context of lymph nodes, so with breast cancer specifically, one of the common things that is done is to biopsy or to do sentinel lymph node biopsy. And that's really essentially to remove the first lymph node that drains from that tumor site to determine, as mentioned earlier, whether the cancer has metastasized or has moved to another site in the body, right? So
Mhm.
it's largely used mostly for staging of the disease, removal of even if the lymph node has cancer cells in it, the removal of that lymph node does not necessarily change the prognosis of the patient in terms of like it's not just because you remove those cancer cells doesn't mean that they're how they will fare and the disease progression will change in that way.
Mhm.
Um, but one of a number of the complications from that is by disrupting the lymphatic system when you remove a lymph node, you're putting patients at other risk. So lymphedema is a common complication that happens, which is just the buildup of lymphatic fluid in the area, which can be debilitating and happens, I believe, in about 25-30% of patients that undergo surgeries at the sentinel lymph node biopsies at the time. And so basically our thoughts was, can we assess the lymph node before we remove it, right? And especially if it doesn't carry prognostic value in terms of, or therapeutic value, can we essentially leave the node there, especially if it's not, if it doesn't have any cancer cells in it, and preserve the lymphatic system without disturbing that. So and then, as I moved into my postdoc at MIT, and more recently, also in collaboration with Memorial Sloan Kettering Cancer Center with this nanoscale technology, it's been taking even one step further, right? So now it's sort of no longer in the operating suite, but now looking at cancer treatments, whether that's chemotherapy or radiation therapy or immunotherapies, targeted therapies. So essentially all the other treatments, but outside of the surgical suite for cancer and trying to determine that. So there it's about, again, trying to get patients to the most effective and the right therapy as soon as possible, because usually once you get to that stage, patients often have maybe a year, maybe 2 years. They don't have the luxury to wait the weeks and months that it currently takes for them to determine not
Mhm.
only is the treatment effective, but if it's not effective, what happens? You have the cancer continuing to grow and develop and so on. And then you also expose patients to the adverse effects of that treatment. And so chemo and radiation and other therapies are not, it's not like taking an aspirin speak in terms of the side effects that you might get. And so, trying to optimize both the good part of therapy, but also minimize the exposure to the bad part of therapies as well. It's been really the goal of that. And I think where we're most excited kind of in the future is going to be, can we now use this information to really not just determine which treatment modality to put patients on, but really get more personalization of cancer therapy. And that's really trying to understand, maybe it's not just therapy A and therapy B. Now we can look at, the combination of therapy A and therapy B. We can now also look at whether sequencing of therapies matter, right? So some early studies by other colleagues at MIT have shown that there's very much a role for, doing a certain chemotherapy regimen before another, in terms of improving the effectiveness of the combined regimen, so to speak. So I think that's the exciting part of, if we can have a better, essentially companion diagnostics that can tell us that information sooner rather than later, we can much quickly iterate on that process of optimizing the right treatment plan for patients.
Mhm. And I'd say like in your work now, on like working on functional precision medicine, using like photonics and nanotechnologies, like can you sort of explain like how these technologies are actually like like almost like revolutionizing the way that like treatment is we approach treatment for individual patients.
Mhm. Yeah, so one of the challenges, as mentioned, right, with targeted therapies, which has been the forefront of precision oncology and really trying to move that field, to again make sure that we pick the right treatment to put the patients on to start with. But in terms of the success rate or how the rate at which patients respond to this treatment, it's not what might first come to mind that, oh yes, it's targeted, that means what, it must be good for 80 or 90% plus of patients. It's not. Right now it's certainly better in terms than comparison to just general chemo and radiation and other prior therapies, but it's still, as I mentioned, 40 to 70% in terms of quote unquote response rate to some of those treatments. And so and a lot of that of precision oncology to date has really been just focused on the genomic side of understanding, right? To know like, okay, this person has a mutation in this gene, so this is what we're going to target in terms of the treatment. But as we now know, what's encoded in the genome is just the first step. What ends up getting expressed is really what matters on the other end, right? And that's why there's been a lot of work around transcription and trying to look also then at the final stage, which is the expression. So looking at proteomics and what is actually ending up at that far end of the spectrum. So some of this newer technology that I've been working on both at MIT and then also with colleagues at Memorial Sloan Kettering Cancer Center has been really to leverage single wall carbon nanotubes as the essentially optical transducer or the sensor technology. For those of you who aren't familiar, carbon nanotube is basically a rolled up sheet of graphene. It's made up of sp2 hybridized carbons. And then we wrap different things around the carbon nanotubes that lead to the binding sensitivity and specificity to different analytes that we're looking to probe for. And I would say up until the last few years, a lot of the effort in our field has been really focusing on, let's build a single sensor to a single marker that we're looking at. And that's been kind of the strategy for a lot of the biomarker development and so on. It's sort of like we understand what the known validated biomarkers are, and then let's try and develop new sensing technology to look for those marks to then move further in the validation of the technology. But now that we've more recently made this transition of now not just looking at sort of a single sensor to a single marker relationship, has been to now look at arrays of sensors to arrays of markers that we are detecting. And so that's really allowed us to broaden our ability to detect now what we're calling sort of fingerprint or of disease states, as opposed to just necessarily like looking at marker A, marker B, and marker C, and then try to understand, what the stage of the disease or what the disease may be. So what that's led to is, so a colleague, Dan Heller at MSK, published I think a couple of years ago now, has been around ovarian cancer screening. There was the fact that, certainly a large portion of the fingerprint signal that we were getting through our carbon nanotubes was attributed to well-known markers for ovarian cancer, such as CA125 and others. But there was still, not an insignificant portion of the signal that we were detecting that was not that we directly correlated to something that was known to be a biomarker for ovarian cancer. So what's exciting about that is it's leading us down the pathway of, are there other unique parts of the blood serum sample that we're seeing that could be also unique to, again, the disease state of the patient, with even for things that we may not currently know about. So I think that's allowing us to have another dimensionality of that personalization to understand, the disease state for that patient. And right now we're diving deeper in terms of trying to understand, is it another marker that is unique to ovarian cancer, or is it a marker that's sort of a combination of things, right? Maybe it's because patients that have ovarian cancer also present with something else, another condition that contributes to that signal as well. So, the long story short is, by now, by having these fingerprint profiles for disease states and for individual patients, trying to now understand sort of what is the response to various therapies becomes a lot easier, because we start with now a baseline, and we can now try different treatments and really close that loop again a lot quicker and really bring that functional part that's of precision oncology. And that's really the other part, is that now we're looking not just at the genomic side, but really, again, what are the proteins that get expressed on the other end? What are those markers that are at the other end that we are detecting
Yeah.
and can measure more readily? So.
Mhm. And sort of shifting a little, could you just sort of, I guess, speaking from your experience as like the founder and the, sort of a leader of the American Physician Scientists Association, just kind of like what sort of challenges, I guess, do you see like facing physician scientists like today, and just kind of like how can like the academic and medical communities um support them?
Yeah, no, thanks for that question. I mean, physician scientists trainees has been an area that's been near and dear to my heart for a very long time. And one of the reasons that I founded the American Physician Scientists Association, which is an organization built by and for physician scientist trainees, was really twofold. One was to create greater awareness around the career path in terms of what do physician scientists do, what is their role in that in the broader biomedical research enterprise, but in translation of, really novel basic science and engineering into clinical medicine, and informing the research community in terms of where to focus our energies to, again, accelerate the process for newer diagnostics, newer therapies that will improve patient care.
Mhm.
Um, but over the years, it's continues to be very similar challenges in terms of facing the training of physician scientists, and those tend to fall in a few different buckets. One is the fact that it's a very long training pathway, as one can imagine. You go from undergrad. Sometimes you take 1 or 2 years after an undergrad because you're still exploring to figure out, whether MD PhD is right for you, as it was in my case.
Mhm.
Um, and then you do both medical school and graduate school. Usually, on average, I think the national average these days is about 9 years to complete both of that training. Some people can do it in 7 or 8, others take 10 or more years. And then most people will then transition to doing their medical residency and fellowship, which is there anywhere from 3 to 7, 8 years on top of that. And then some people will then further that by, now that they've been so much on the medicine side, a lot of people tend to want to spend another couple of years kind of reintegrating back on the science and research side before they would start their own independent research lab, whether that's through their fellowship and their clinical fellowship. Sometimes there's research time built into there, or kind of taking a completely independent, whether it's an instructor position or a postdoc researcher position after their clinical training, but before transitioning to a faculty position.
Mhm.
So if you add it all up, it's easily, almost a couple decades of training after you finish your undergrad before you could start your own independent career as a physician scientist. So I think that's been one of the challenges in trying to think about, like, how can we think about a different paradigm for training physician scientists. Essentially, how much training does one truly need in the science side and the engineering side? Because there's a couple of goals you're trying to. One is you're trying to train people on knowing how to do good science and engineering, but two, um, you also want people to gain enough experience to essentially become an expert at this very niche base that they're working on, right? And that is potentially the launching ground for what their faculty positions and their independent research labs focus may be.
Mhm.
Um, the other has been around the mentorship aspect, and that's really the fact that there's not a ton of physician scientists. Obviously, there's plenty of physicians, there's plenty of scientists,
Mhm.
but the type of mentoring and advising a physician scientists need that, it's not. I think the biggest pain point that I have is trying to tell people that it's not that you're a physician and that you're a scientist in terms of what your career is. It's really a melding of these two careers, right, into its own unique career. Oftentimes, physician scientists are compared to purely physicians or purely scientists, and that's really not a fair comparison because we will never be able to spend 100% of our time in both of those as part of being a physician scientist.
Mhm.
So having good mentorship and a good support network, especially because it is such a long pipeline, is crucial to the development of physician scientists.
Mhm.
Um, and I would say probably the last part is around the financial component. And yes, during the MD PhD, you get med school paid for, you get a stipend, and so on. Um, but if you think about the length of a physician scientist training, before by the time that they're able to again have their own independent career and they're not still in training, they're usually somewhere in their mid to late 30s, sometimes even early 40s before they start their career. And if you have to think about somebody's goals, life and personal goals along the way, whether that's their parents getting older, whether that's them starting a family, starting to buy a home, etc.
Mhm.
There's a lot of other things that come into play that makes it challenging sometimes for people to think about like what all this the financial incentives, so to speak, of making this work realistically. And so that's financial more on the personal, but it's also thinking about financial from a professional level. And by that I mean sort of having adequate funds available to launch the careers of physician scientists, whether that's having enough physicians out there that for physician scientists to start their own faculty labs, whether at hospitals or at universities and so on. So I think there's a lot more that can be done in terms of professional development and support from different angles, like I said, mentorship, but also financial as well. So.
Mhm. Awesome. And this is just kind of, so yeah, thank you for that. And just sort of last question to wrap it up is just um, for the physician scientist trainees themselves, um, learning how to like bridge medicine, science, technology, engineering, and just kind of like what is like one sort of piece of advice you'd offer to them and how they can like prepare for the challenges and opportunities in this field.
It's a really good question, and it's really narrowed down to just one. So I'll cheat a little bit and probably cover two areas. One is to really follow your passion. Find out what you're truly excited about, what you're really passionate about, because that will continue to be sort of your grounding motivation for both the highs and the lows of this career path. Um, is where I would start. I think the second is whatever you do, just go as deep of a dive as you can. Don't leave any stones unturned. Like really, if you're gonna be in your PhD side on the science side for a certain number of years, like just dive deep on the research side and try to really become an expert there, gain that knowledge there. But I think that's so it's the intensity of that depth. I think that is truly important because otherwise, staying at a high superficial level becomes challenging because then you sort of become a master in multiple domains, sort of, but not fully. Right? So.
Mhm. Yeah, well, thank you so much for sharing that advice, and thank you again for coming on and sharing, talking about your work and your experiences. It was wonderful to have you on.
Yeah. Well, thank you so much for having me on, Arif. It was really a pleasure, and I had a lot of fun.
Awesome, great, me too. Well, you have a great rest of your day.
You too. Take care, Arif.
Bye bye.